I think it's discussion time.
Well, I would agree. I'm Eric Skumaker. I'm from the Uniformed Services University. I would agree with what you've said, and especially what Dan pointed out. I guess because everything looks like a nail when you're a hammer, we in the military would call this a campaign plan. What you need is a campaign plan. And every campaign plan consists of lines of effort around what are the principal tasks that are subordinate to getting to the objective you're looking for. And you've identified some of the principal lines of effort, whether it be information campaigns to consolidate the evidence. The NCCIH is a very valuable tool for that. Dr. Chow is a great tool for that. Whether it's informing the public. I mean, one of the conversations in the hallway was, why don't we just tell the American public they've been sitting at a buffet for the last 50 years and they've been given half the meal. In fact, the half that they've been given has got poisoned water and bad food. Because we're killing them. We're killing them with drugs and we're killing them with procedures. Clearly, I should not be on this task force. I'm trying to make the case for not being a part of this. But I think that the task group that you're putting together, I think the first and foremost thing it needs to do is to develop a campaign plan that has a very, very clear set of lines of effort, 3 to 4 lines of effort that you've outlined. Wayne Jonas, about 3 years ago, I was privileged to work with the Samueli Institute as a representative of the DoD for them. And the Samuelis put together a task force with about 8 institutions, 3 within the Department of Defense, 1 within the VA here at the VA Medical Center, and 4 civilian groups. Bastyr University was one of them, Southeast Naturopathic was another, and then we had a very large chiropractic group out of Bridgeport, Connecticut, and in a multi-specialty clinic out of Oklahoma City. And we worked using the Institute for Healthcare Improvement's process of iterative improvement to look at how would we develop a chronic pain program effectively across all these spectra. And they came up with 4 major areas, very similar to what you all have done here. I would submit that that would set you on a course for a campaign plan to make that happen. Thanks.
Thanks. Microphones are empty. I knew that would get somebody.
Can't stand to have an empty microphone here. You know, in just thinking about
Identify yourself.
Oh, I'm sorry, Christine Gertz, Spine IQ. And thinking about what each of us can do and if there's some way to do it in even a quasi-coordinated manner, because I don't know if everyone feels like I do. I'm ready to take to the streets. You know, I'm ready to do something. I don't quite know what that is, but is it possible to get contact information from, or are people willing to share their contact information with other people that are here at this workshop so that we're able to, I know I've had a number of really great initial conversations that I'd be interested in following up, and that may be a way to start some of those more informal processes that Dan described as we wait for something more formal to come out of this. And my second question is, I mean, do you have a plan? I mean, do you and Dan, I mean, is there something you think, well, I'm going to do this on Monday? I mean, just to even start out,
I have a lot of ideas. I don't know that I have a plan, but yeah. But I mean, yeah. I mean, obviously, I think going back, Christine, I'm sure contact information can be shared, from everybody that's here. But I think what you're asking for is there a plan for a plan? How do we start? And I think that's something that I don't really have it in my head right now. I don't know if anybody else has ideas, but I'm more than willing to work on that, honestly.
Well, I'm going to share a conversation we had over lunch and sort of the question, are we on the verge of a takeover? Because we know that the big tech companies are moving in. Amazon, Berkshire Hathaway, they're taking it upon themselves to find a solution to healthcare.
Yeah.
And they're bringing in a lot of technology. So if we are on the verge of a takeover, maybe we should collaborate. So maybe an action step would be to reach out to them and see what interests we might find in common.
Yeah.
So,
Good.
David Shurtleff, NCCH. I think this has been great, and I think I really appreciate, Dan and Tony, your perspective and the idea that we need to keep the ball moving and moving forward. And it was a great energy in this room, and I feel like I should be singing Kumbaya or something, but no, it's great. But I think we need to also be mindful of the fact that there are programs in place now that can help, maybe even in a modest way, move the ball forward. So not to beat a dead horse, but the initiatives we have through the HEAL initiative, the pragmatic work that I talked a little bit about yesterday, the fact we're engaging CMS on looking for evidence for chronic, acupuncture for chronic low back pain in older adults, the pragmatic approach looking at how we can implement healthcare clinical guidelines, the fact that those are things already in place. I don't want to lose sight of that, and this is the community that's going to respond to those initiatives, and success begets success. So if we can make some headway here with this little, what I might call a modest step forward through the NIH HEAL initiative that NCCH is playing a role in, if we can do something really significant here, and not to mention the VA-DoD partnership with NIH, if these are proof of concept from the research perspective, if we can show that we can work together, build a successful sort of fundamental basic science pragmatic research, I think we can build on that. So I think everything talking about the future is great, and I don't want to dampen that momentum, but the time is now, and there are initiatives already on that will be on the street like within the next few days. I don't want to say too much more. So I think paying attention to what we already have and building on that for the future, if that makes sense.
Great point.
Monica Gross, the POISE Project, Alexander Technique for Pain Management Initiative. Speaking of the future that David was just speaking about, I would like to advocate for people who aren't here, which would be children and youth, and how if we want to start a chronic pain prevention initiative, a great place to start it would be in primary, secondary, and tertiary educational systems, preferably public, and that's obviously a challenging project, but it's a doable project. You can build towards it.
Yeah.
And there is an interest. There's already programming that is moving into our public school systems. It's more acceptable. Parents are accepting it more. Administrators are accepting it more. So I think if you give skills to people when they're young, so that when they meet those challenges later in life, which might include pain following an injury or surgery, or the development of pain from occupational situations or others, they're going to already have a paradigm of self-management, of choice, of self-analysis, of patience, and other skills that will help them meet that might not lead to the situation that opioid prescription is filling now for people. It's been a very passive system. We could activate the population in self-understanding and education.
Go ahead, Margaret. You were.
As a former person at NCCIH, or at the time NCAM, I'm trying to think of things because I think that time is of the essence. And we need, I'm not in the military, and I should have checked this out with Eric or Tripp, but I think we need to have sort of a battle plan. And I think that people are dying every day. And while I applaud all the initiatives, those are incredibly important, but people have to write the proposals, they need to be reviewed, and there's kind of a clock on those. So that's good. I mean, that's like, okay, that's like moving the ships out, right? That takes a while to get them there. But I think we need to think more creatively now. And we need some funding, I think, for a task force that could meet over time, or just some support for that. And I'm not asking for myself. I'm asking for people in the room that want to do that. I think that might be helpful, to some support for that. That could be done through, just maybe supporting some convenings, adding a day to meetings where some of these people are already going to be together, if there are such times. Also thinking about this analysis issue that Sherry and others brought up, I think there are probably existing databases that would give us a head start, and maybe some way to pull some people together to get administrative supplements to look at data sets in existing studies where people could quickly propose to someone, maybe to NCCIH, to do some analyses. That would be short term, that would actually inform other things. And I think you have the collaboratory. Maybe that be a way to have the collaboratories that you have. I'm trying to remember everything of the last 2 days. But to really set out a plan of near term, because people are not going to, even if there are some new drugs that are developed, they're not going to meet the needs that we're talking about here. And they don't really address some of the things we just heard summarized. So I don't think we're talking about filling the gap until the magic comes. Because I think this is an opportunity for us to say, you know what? The magic isn't really in one thing.
Right.
It's in a lot more. So I hope that just gives some ideas, because it's been long enough that I was at NCCIH, I can sort of talk about some of these things, and this seemed to be the first place I could do that. Thank you.
Thanks. Liza?
Yes, I've been a member of the Global Forum since we began 7 years ago, and as you know, we academics go quite a bit slower. But I think in the Global Forum, what we have really gained an enormous amount, and I have no question that it has impacted nationally and globally the movement towards collaborative team-based care. But I want to ditto Eric. I actually think a national campaign, and what Bo said, bringing in some of the mega corporations that are very interested in this area, because we certainly together are much, much stronger, right? We have a great examples of elements that are going on, but if we come together and have briefly convene, because I think we are poised to move forward and create a national campaign that includes a lot of public education, I think that would be very effective. What would be so disheartening with everything we have heard over the last 2 days and so much enthusiasm, if it goes into a printed copy and we all receive it and we share it somewhat, but if it doesn't go out broader, I think that for me, and I think for many in this room, would be quite disappointing. So, Eric, I ditto your suggestion.
Nancy?
Nancy Baker from Tufts University. Just as a plea, any task force, lots of patience, and lots of people for underserved populations. We need to get people who are from the lower socioeconomic status, who are going to understand some of the problems that could be barriers that we may not know about. So that's just my plea.
Thanks.
Hi, my name is Alyssa Wistrel. I'm the Executive Director with the Academic Collaborative for Integrative Health. I just wanted to speak to, first of all, to echo Liza Goldblatt's comment right now on a campaign. I think that could be an opportunity that we can marshal the passion that's in the room and that is needed to be expressed holistically in the communities at large that really are suffering and need our help, need our assistance. So I agree with the idea of a campaign. Secondly, I've noticed today and yesterday that the K through 12 idea of whole health education has been brought up repeatedly, and I just want to speak to that I'm a member of an advisory board for an organization called Whole Health Education, and it is about the vision of creating a curriculum around wellness education for K through 12 in the public schools, public and private sector. And there's a model that is taking place of this in New Jersey. And for those of you who are interested, you can contact me off the contact list for more information.
Thank you.
Wilson Compton, National Institute on Drug Abuse. We've heard a number of terrific ideas that will keep all of us occupied for quite full-time for quite a while. I really want to loop back to one of your original concepts, which was possibly using the licensure exam as a tool to be something that everyone reaches for that has a specialty. I would also think I've heard this highlighted before. It's not as easy to change as it seems. You don't just do it one time, but you got to have a cadre of people that write questions for the exams themselves, and you have to set that up in a long-term way to make sure that it reflects the emerging and changing science. So it's complicated. But I would also say beyond thinking about sort of the original medical licensing exam, think about specialties. I'm looking at a role for the board specialty exams within key areas of medicine in particular. I think about some of the surgery specialties where I'm not sure that pain treatment is such a key component of those exams. And yet that might be a major way that we could fairly quickly change practices in a very practical way. So I would second that. That somewhat narrow, but I think a potentially very useful way to shift the educational system, because everybody pays attention to what their students have to take at the end of the day.
Thanks.
My name is David O'Brien. I'm the president of the Association of Chiropractic Colleges and the chair of the Academic Collaborative for Integrative Health. I want to start out, you don't stop and think of moments. This is an historic moment in the healthcare revolution, and you guys are all part of it today. I'm a native of Washington. I see lots of things happen over the years and decades. This is an historic moment that you got to stop and take stock of. A moment where you guys can make a difference in campaigns. And it's a moment where there seems to have been great consensus the last 2 days of what you all have delivered in terms of the presentations and where we're going with our research and what we have. You've had federal agencies reach out and say they need some help from the research side of things, and we have to have the public policies that allow those agencies to do that. That requires change, and those of us that are not in government have an opportunity to make that change. So I would encourage everybody that I do believe in the campaign. I think making a public policy consensus statement from the Academy has great meaning, and by uniting behind that common cause, you can really make an impact. And I think now is the time where the Congress has got 100 new members as of January. They are young and uninformed. When I first went to Congress, I was 22 working for Congress. And I remember working on intellectual property law, and I remember saying, I just got my first Visa card. That's how uninformed we are for the young people that are coming in. We have an educational opportunity that is really timely. With that, I'll sit down.
Thanks.
Join the revolution. I also want to reiterate what a number of people have been saying here about that this is a very unique group, and we've got some consensus, and I just really want it to go forward because inertia could take us over very quickly. It's too easy to continue doing what we've always done. I definitely hear the needs for research, especially for CMS to have the older populations. But I also wonder if we can trigger several, with this task force or whatever, that we go after several trigger points. One being the exams that were just talked about. You change the questions in exams, someone has to learn it. And they have to be covered in it and go on from there. I heard the other day about school accreditation, that if that school has to have their competencies in line and to get accredited, they'll make a way to make that work. If we have quality metrics that are around pain care that are required for reimbursement, or that the points get taken away from a hospital if they're not doing this, the Joint Commission is already on that. That's going to be a leverage point. Like was Tony just said here too, is that if those kind of leverage points change, change happens fast. I mean, because everybody will say, oh, we can't do that, but then they'll do it. And we don't need to figure out ahead of time precisely how to do it, because it may look different in different places, and some of those natural experiments will do better than others. So if we can find those leverage points and get them going, yes, I think things will move.
Hélène Langevin, NCCIH. So I totally agree. Obviously, education is hugely important. Education of patients, of clinicians, of all the people who need to be educated, obviously. But I want to echo David's comments about really taking full advantage of this amazing opportunity that this HEAL initiative is going to bring to us, and to make sure that we do the absolute best science that we can. That's very, very, very important. And science, good science, is informed, right, by other people than scientists, namely clinicians, right, patients, and people who have a stake in this, and making sure that the science that gets done is the right science that needs to happen. So it is a group effort. And so I think that, for scientists in the room, I would certainly absolutely encourage you to take a very good look at all of these new opportunities that are going to be coming out just very, very shortly. But we have to be together in this. We can't just say, oh, it just takes too long and we need to just do it fast. The science needs to continue happening. So get to work.
Last word.
Well, as a researcher, of course, I'm going to pay attention to what David and Hélène said and apply for the grant. But while we're waiting for the results of those, as a patient, I've sort of given up on the medical system.
Absolutely.
And, we need help from lots of people, but maybe not from the people in this room. If we go to Oprah or we go to Hollywood or someplace like that, those guys, when they get a new movie, everybody knows about it. And why don't we partner with some of our friends in communication and start getting some of this stuff out? I had this dream of a website. It probably needs to be on a mobile phone where you could go and you could, depending on your favorite demographic, if you're a man, if you're a veteran, if you're an older adult, or if you're an adolescent, you just log in, and then you find a provider who can talk to you because they've had your problem and they know about their therapy, and you can check it out and hear the stories, and it's all evidence-based and stuff like that. And then you can update it as we do our research, and not have to worry about oh, do I trust my doctor or not? We just brand it in a way that it comes from some august body, and make it fun, because that's what the newer folks like.
Another comment. Hold on.
I just wanted to say thank you for including someone from a little bit north of you. And I'm very impressed with the variety of work that you're doing. And I guess one piece of advice from my old age is don't start recreating something when you have so many strengths here. If there's any way that you can use what some people have done and build on it. I think going forward, whether it's with the national agenda, whether you're linking up with, larger industries who are trying to build their own sense of healthcare. But there's amazing work in this room with leadership, and I'm impressed by the funding that some of you have available. So I would recommend whatever you do, don't start recreating when somebody here has already provided a baseline. I've really enjoyed meeting people and listening to what you're doing, so thank you very much.